Grand Rounds. I'm Tom Reynolds, one of the pediatric neurologists and leadership in the residency. For those of you who don't know me, it's such a pleasure for me to get to introduce Dan Trigg today. Dan is one of our senior residents. Dan has a real passion for advocacy, and he's going to give us a great talk today. Dan graduated from Hamilton College in 2005 and took a unique pathway to medicine, worked in finance for about 4 to 5 years before becoming an EMT and ski patroller in Vermont, where he really found his true calling in being an outdoorsman. Ultimately went to UVM. He did some great work there, working with high school students in a MedQuest program for those interested in medicine, and also had some special interest in the care of children with mitochondrial disease. Dan has been a wonderful part of our residency these past 3 years. He has taken his love of the outdoors and worked on a great advocacy project, which he's going to share with us today. And his topic on bicycle helmets, he's headed off to the University of Rochester next year for a fellowship in hospital medicine. Dan, take it away.
I'm Daniel Trigg. I'm a third year in pediatrics, and I'm going to be talking about bicycle helmets today, specifically how they work, the injuries they prevent, and why we're distributing them from the resident clinic. And I want to take a sec to emphasize that I love bike helmets, and I really like biking. This is a picture of me in the Utah desert. And as you can see, my front wheel is about to come out from underneath me, and I'm about to take a spill. And this is one helmet I think I may have cracked. So let's get started. So to access this Grand Rounds, please, and to get CME, please text to this attendance number. And I want to emphasize that I have no conflict of interest. In terms of the things we're going to cover today, I'm going to provide an introduction to bike helmets. It's going to go over the type of protection they offer, the technologies involved, and how they fit. And then I'm going to go over the added safety that bike helmets provide to children when riding bikes. And I'm particularly going to emphasize that they reduce the chance of skull fracture, upper facial fracture, significant head injury, and TBI. Then I'm going to talk about my advocacy project, which promotes the clinic bike helmet distribution program as a really easy and effective way to increase helmet use among the children we serve in and around Portland. And I'm going to show that that population is at increased risk of not using bike helmets. So again, we'll talk about how helmets work, how we got to this point, why we need them. We'll talk about our clinic population. We'll talk about what we've done with giving out helmets so far. We'll go over some data briefly. I'll talk about some conclusions and next steps, and then I'm happy to answer any questions or other things that come up during this talk. So South Portland, Maine. So unfortunately, a spring day in South Portland does not look like this. This is actually a photo of an organized bike ride from the Maine Bicycle Coalition. And I think in my neighborhood in South Portland, I've seen helmeted children maybe a total of 5 times in the 32 months I've lived there. And to me, that seems strange to me when I compare it to where I'm from in New York, where helmet rates aren't great, but I'd say around half of kids are helmeted. There's more of them. And to me, that reflects what the data shows. States with helmet laws that are enforced and combined with community outreach, like in New York, get about half of childhood riders helmeted. And to me, that juxtaposition marked the start of my journey into bicycle helmets. And I want to add, too, that Maine has a bicycle helmet law, and that's not unusual. It was passed in the 2000s like it was in many states. And there's nothing all that unique about Maine compared to other states with helmet laws. But just to start off, do children need to wear helmets? Yes, they 100% definitely do. They prevent skull fractures, TBIs, facial injuries, and more. This is one of my favorite quotes from a pediatrician, Dr. Oken, who's done a lot of work that's been published in Pediatrics and Pediatrics in Review on bicycle helmets. He said, those who die in bicycle crashes are 3 times less likely to have been wearing a helmet than those who survive. Proper helmet use has been estimated to have a protective effect against brain injury between 60 and 88%. So there has definitely been a boom in bicycling due to the COVID-19 pandemic. The number of bikes sold at shops compared to 2019 is up 65%. There are literally empty shelves at bike stores, and obtaining a bike in some cases can mean waiting months, and bike helmets are selling out too. This is an article I read about the increase in use in Seattle. The city of Seattle simply sat there with a counter and really measured how many people were using recreational trails. They found it was up 22% during the pandemic year. And I want to emphasize this increase is much larger than the increase we saw in the 90s during the interest in mountain biking and during the 2000s due to the road cycling craze that Lance Armstrong helped facilitate. And that should really matter to us as pediatricians, because more of our patients are out there riding bikes ever before, and they need helmets. Helmets offer protection. So why do helmets offer protection? I'm really going to explain what they do. There are really three clear mechanisms, and all of them involve protecting the brain tissue itself and the blood vessels that supply it. So first off, helmets have a polished or slick exterior that allows the head to slide when it comes into pavement. And that theoretically reduces rotational forces, and rotational forces are linked to brain damage. Second, helmets distribute the force across a broader area. So for example, if you fall and a sharp object comes into contact with the head, the foam of the helmet spreads the impact out across several square inches. And the last part is really key and the most important. The helmet, like when you crash into a hard surface, actually crushes, and that controls the crash energy and extends the head stopping time by about 0.006 of a second. And that reduces the peak impact to the brain. That's really important because the helmet reduces the maximum amount of force. In other words, it spreads out the force over more time. So with that, per this graph here, if we assume X is the time, the X-axis shows time and the Y-axis shows peak force. With no helmet, we see there's a greater spike. Whereas with the helmet, there's a more broader period of increased energy. And interestingly, though, as we'll learn, helmets do not reduce the incidence of concussion. They can offer some protection against some injuries by spreading out this force, but they don't reduce concussion. So helmets undergo rigorous testing standards. And this video introduces some concepts I'm going to go over later, but let's for now watch really quickly how a helmet is tested. And this video just quickly shows the anvil test being performed by researchers at Virginia Tech. It's one of several impacts that the helmets are tested against. And basically a helmet gets dropped on an anvil, and then there's sensors in the dummy head that determine the amount of force that the helmet and the head were exposed to. And in case you're wondering, they do this at different temperatures because we live in Maine. So I'm just going to quickly play this.
System aims to analyze helmets in kind of a range of impact scenarios that are known to be seen in the real world. And take a helmet and we subject it to a number of impacts with 6 different locations and 2 velocities, which are then summarized into 1 performance rating.
Of the 30 helmets first tested by Virginia Tech, 4 earned 5 stars. All of them were road cycling style helmets, and they were all equipped with MIPS for the PT.
So we're going to talk more about this, these best performing helmets and why they perform better. But moving on, how did we get to this point with helmets? And in short, helmets kind of came onto the scene in the 1970s. There are really 4 distinct periods in helmet development. In the 1970s, there's a recreational cycling boom, and that led to the development of the first helmet. In 1975, Bell Sports came out with the Bell Biker, which is really a modified motorsports helmet for like dirt biking and urban motorcycling that was made of polystyrene foam, and it had a very hard Lexan shell. That's the stuff that early Nalgene bottles were made out of. And it was really the first modern bicycle helmet. And they're very similar to the modern skateboard or urban style bike helmets that we see. They had a hard outer shell. It offered quite a bit of posterior protection, but it was heavy and they were really tough to properly fit, and they were deemed not too comfortable. In the 80s, we started making helmets out of styrofoam. And that's kind of interesting because styrofoam helmets are really made of the same stuff we make coolers out of. But we put a Lycra nylon cover over them. And while they were lightweight, the foam wasn't too tough and they could crack pretty easily or even shatter on impact. And again, they were pretty tough to fit, these pre-molded pieces of foam that we assumed would fit every person's head that we put it on. In the 90s, helmets advanced further and took a big leap in that they became made out of injection molded foam and were offered in more sizes, and the ventilation improved. So they were still kind of tough to fit, but they became more comfortable and it became more likely that people would wear them. And then during the 2000s, helmets kind of took another leap in that they started to offer occipital lobe protection or occipital retainers, meaning in the posterior of the head, they had this area that would essentially tighten up and hold the helmet in place. They also became more stylish and they got easier to fit. So there's been quite a bit of evolution in helmets. There's also been quite a few advances more recently, most notably the MIPS system. The MIPS system, it stands for the Multi-Directional Impact Protection System. And it kind of addresses a shortcoming in traditional bicycle helmets, which is that helmets in and of themselves can increase the torque applied to the head during a crash. The sides of the helmet can literally act like a lever and pull the head. And that twisting motion has been linked to concussion and brain injury. So MIPS is a patented slick layer of plastic that effectively sits between the rider's head and the helmet. It's really an immovable cage within the helmet that allows for slippage between the head and the helmet. So during an angular impact, the helmet slides on the low friction MIPS plastic and minimizes what we call rotational violence on the brain. So rotational forces, again, are linked to concussion and serious brain injury. MIPS can help minimize them. I'm just going to show a quick clip right now about how MIPS works. So again, MIPS is this slidable layer that adds extra protection. There's also another new technology that's kind of interesting called wave cell, which is really made of hundreds of interlocking collapsible cells that kind of form this rotational suspension that forms an inner helmet liner. And it really does three things. It flexes to divert forces away from the head. It crumples, almost like the crumple zone in a car during a collision. And it also glides, meaning it kind of like smushes and slides along the head to cope with those rotational forces we learned about. This is just another short clip about how this system works.
And impact came into, and it's that whole process that led to wave cell. Wave cell structure has a specific cell shape that makes it deform into a sphere without distorting itself. Using a continuous liner, it's suspended inside a helmet. It behaves differently depending on the angle that it's hit at, which is very unique to the material. Each cell has a small fold in it that helps in initiating the crumpling for the straight impact, but most importantly, it allows the cells to fold over in shear. It would allow the helmet to spin on itself rather than imparting that spin to the head to cause the concussion. Take the standard force and a threshold at a given angle of impact. You can calculate what your risk of concussion would be.
So is there really any evidence that these work? So in short, these new technologies have been tested in the lab against standard bike helmets. I looked at one study by Blyden here that essentially exposed these different types of helmets with these fancy new slip layers to a rotational impact on the anvil. And they found that MIPS and wave cell helmets reduced this rotational acceleration that's so bad by 22% and 73% respectively compared to a plain foam helmet. But the problem is that we don't really know what that means clinically. Like no one has actually studied whether or not that reduces the chances of a bike rider, whether it be a child or an adult on a bike, from having a concussion. So interestingly, they reduce this force. We just don't know what it means for the real world yet. So helmet choice matters. It's not necessarily so important to get a new helmet with MIPS or wave cell as it is to just get the right kind of helmet. And I want to take a minute to talk about this. Urban style skate helmets like this Burn Watts helmet here on top are kind of more stylish, and they problematically though kind of lack foam protection along the sides of the head. That's considered the most vulnerable portion of the head. That's where we have the middle meningeal artery, deep, and a bunch of other sensitive structures. So there's not as much cushion, and these helmets are more so designed for skateboarders who repetitively take minor falls backward onto the back of the head, not necessarily forward or side bike impacts. And they don't perform as well, both on the street and accident reports, as well as in the lab. A better, safer choice is a more traditional bike helmet, like this specialized Chamonix MIPS, because there's thicker foam on the sides of the head, and these helmets are designed to take forward and lateral impacts at 10 to 15 miles per hour. They perform better, they're better studied. So the takeaway from this is that children should wear properly fitted traditional bicycle helmets, which we'll talk more about. And helmet fit is everything. You can have the best helmet, but if it's not fitted properly, it's not going to work. It starts with an accurate head circumference measurement, and the good news is that we're used to taking those in pediatrics. We take them all the time. Pardon me. And because of that, we should be good at fitting helmets. So what we really do is we make sure we have the right helmet with a good head circumference fit. And then we make sure that there's a side strap on each side of the ear. The buckle should also be under the chin and snug. Two good measurements to take per this list here are to make sure the child can only put about a finger or two beneath the lower buckle and a finger or two beneath the brim. And there should be no movement, like a child should be able to yawn. A child should be able to wiggle, and there shouldn't be really the helmet coming over the eyes or sliding further back. So again, fit is everything. And unfortunately, children use helmets that do not fit. I looked at this study that took place at a private pediatrics practice in Falmouth, Mass, in which they had 395 families bring their child's bike helmets into well child visits. And each family completed a questionnaire and made their best attempt to fit the helmet to the child's head during the visit. And they found that 96% of the helmets were in inadequate condition or fit poorly. They had poorly positioned straps, the helmet rested too high on the head, there was excessive movement. And helmets can, have hidden damage, just like the one in this picture with this small microfracture in the back. So to recap, helmets allow the head to slide side to side, allow the head to slide along the pavement, and that prevents rotational injuries. They distribute force across a broader portion of the head. They slow the rate at which the brain comes to a stop. And there's some pretty exciting new technologies in them that may or may not improve safety. And helmet fit and choice are key. And it's important that children choose traditional bicycle helmets, and it's all about the fit. Again, you can have the best helmet, not a great helmet, but if it doesn't fit, it's not really going to work well. So I want to take a second and emphasize that children are vulnerable to injury. The CDC comes out with these statistics every 10 years. Unfortunately, they're about to come out with the new ones. These are a little old, but 33 million children ride bicycles each year in the USA for about 10 billion hours. 384 of them die due to injury related to biking. 450,000 are treated in an ED for an injury that occurred while bicycling, and 153,000 of them are treated for head injuries. That's a lot. And pediatric TBI. So pediatric TBI is a devastating, very sad diagnosis. There are 145,000 children living in the USA with TBI, and NHTSA thinks that maybe around 10% of them are related to bicycling or some kind of pedestrian issue that occurred. And the healthcare cost for taking care of them is between $1 and $3 billion a year. And per this article in Peds in Review, it's really difficult to quantify the pain and suffering that these children go through. But bicycle helmets work, and we can protect them. And I'm going to talk about how they prevent TBI, skull fracture, and facial injuries. So helmets prevent TBI. This study was a prospective cohort that looked at bicyclists that presented to New York City's Bellevue Hospital. It's a major trauma center that serves Lower Manhattan and Western Brooklyn. And there were 699 bicyclists, and about 40% of them were helmeted. And the researchers wanted to delineate the types of brain injuries that were impacted by helmet use. And I really liked how this study was a prospective cohort. It's part of the reason I included it, because the study design kind of like in of itself reduced patient recall bias. It decreased the risk of missing patients after hospital discharge. But the disadvantage of this study and a lot of bike helmet studies that it only covered patients who presented to the trauma center, the ED, and reported these injuries. In other words, like it misses patients who crashed and then just went home and coped with their injuries. It misses patients who sadly died at the scene. And to be clear, this is a study of patients who between 2012 and 2014 who came through the ED and reported their injuries. And it looked at adults and children. And it showed that bicyclists are who are helmeted are less likely to sustain intracranial injuries. And these are injuries that cause TBI. So for any acute intracranial injury with no helmet use, the injury rate was 19.7% compared to 6.3% for those with a helmet. For subdural hematoma, 8.1% versus 0%. For epidural hematoma, 5.8% versus 0%. So clearly helmets help. This is a study in Marin County, so near San Francisco. And this one analyzed a database of 906 patients that presented to Marin Health Medical Center, which is this level 3 trauma center, again, in the Bay Area, between 2007 and 2015. And what's so neat about this study is that so many of the riders in it were helmeted. And that's because it's in an area where helmet usage is the norm. And it also was in an area in which there were several rental shops who insisted that the bicyclists who rent the cycles wear helmets. So instead of there being a study in which 20 or 30 or 40% of people were helmeted, and this one was closer to 80%, I thought that was kind of neat. They had very clear definitions for concussion, serious head injury, and I want to add concussion was the most commonly reported injury in the study. There were 385 cases of it, or 42% of injuries. And helmets prevent serious head injury, not concussion. I can't emphasize this enough. Helmets decrease skull fracture and major head injury. So there's no difference in the amount of concussion injuries in helmeted versus non-helmeted bicyclists. And to me, that makes sense because helmets neither prevent the brain from slamming into the interior of the skull after a sudden deceleration or the bounce back or contre-coup injury. As we talked about, helmet technologies are attempting to reduce the rotational forces that do that. But again, we don't really know what the impact of those technologies is yet. So helmets may decrease that peak force we talked about, but they do not reduce concussion. And again, they decrease skull fracture and some other major head injuries. So interestingly, this study also showed, and again, the p-value wasn't significant, so it kind of hints at the fact that helmeted patients may spend less time in the hospital regardless of their injuries if they do happen to be admitted. Interestingly, there's currently a study in process in Michigan that's looking at hospital stay among helmeted versus non-helmeted riders. And bicycle helmets can also prevent some facial injuries. So facial injuries can be really serious, life-changing events, and they can have really severe consequences. I feel like in the literature, they're often kind of downplayed compared to brain injuries, but it can be devastating to lose the structural support of the face and there's bone damage. There can be disfigurement, vision problems, problems with mastication, even speech can be impacted, and they should be taken really seriously. And this study looked at adults aged 18 to 65, but I felt that it was a higher quality study than a lot of the ones that involve children, mainly because of some of the graphics, which I'm going to show you in a second. But to me, it does apply to adolescents because adolescents have similar facial structure to adults. And this study was a retrospective cohort that looked at about 85,000 bicycle crashes from 2010 to 2014 that were reported in what's called the National Trauma Data Bank. And so it essentially just collected information regarding these crashes from emergency departments. So helmets protect the upper face. And this graphic kind of shows the distribution of facial injuries in helmeted riders. And note the increased protection offered to the face. The closer the impact area is to the helmet, the less the chance there is for injury. So the risk reduction from wearing a helmet for fractures to the upper face compared to the lower face is 52% versus 21%. For soft tissue injuries is 30% versus 2%. So again, you get this upper face protection, which is kind of neat. So I want to add that some in the bicycle community are advocating for helmets that cover the full face, or at the very least helmets that almost have a bar in place to protect the face, almost like an NFL kicker helmet. But these helmets are less comfortable and less likely to be worn. Per study that I read from Germany, they cause hearing impairment. They can reduce peripheral vision, and they have poor heat dissipation. They're also a lot more expensive. So to recap, bicycle helmets prevent TBI, as well as serious intracranial injuries, such as epidural hematoma, subdural hematoma. They prevent skull fractures, and they also prevent facial fractures and soft tissue injuries to the upper face. And bicycle helmets may even reduce the length of hospitalization if a patient who crashed gets admitted, again, currently being studied. But again, bike helmets do not prevent concussion. Can't emphasize that enough. They'll prevent skull fracture, other forms of head injury, but they do not prevent concussion. And that's been shown in multiple studies. But children don't like to wear helmets, and that's an issue. And this data comes from states with past enforceable bike helmet laws like New York and Minnesota. And even states with educational campaigns and helmet giveaway programs get 50 to 60, sometimes 70% use among children maximum. And I looked at a study in Minnesota that effectively just like would stop patients on a bike path to see if they were helmeted or not. And they came up with these percentages by age group, and they found that the lowest percentage among all groups was those 11 to 19, 31%. It was a little bit higher for younger children, age 7 to 10, 44%. But really, helmet use was highest among adults, 50 to 59. So again, helmet use is not that, it's not all children wear helmets, even in states that have helmet laws. And that's for a slew of different reasons. This has also been really well studied. This is the study from Pediatrics, the same one, where they didn't try to figure out why children weren't wearing helmets, and they simply gave them a questionnaire. It was a cross-sectional study that had just over 2,000 surveys returned, and it included 584 children and 1,377 adolescents, so a good amount of kids. And the most common reasons kids cited for not wearing their helmets were that it was uncomfortable, they found it annoying, it was hot, they felt like they didn't need it because they weren't riding competitively, or the children simply didn't own one. And what's kind of interesting about this is that the highest risk group was adolescents, and in particular adolescent males. And per the survey, without getting into all these sophisticated responses, they just didn't seem to acknowledge the risk of not wearing a helmet. And that's kind of like a theme in helmet use among children and adolescents, that adolescent males in particular are at high risk of not using a helmet. And we have a population at risk right here in Portland. That population being the children we serve in the pediatrics clinic. And I love this study. It's from Canada, and it deals with about 26,000 children across 8 provinces in 436 schools. And it gathered information from this survey that children complete every year called the Health Behavior in School Aged Children. And the survey is kind of designed to look for health disparities among Canadian youth and to establish subpopulation groups that might be disadvantaged that the Canadian government can then address. So it looks at people who immigrated recently, it looks how much their parents earn, it looks at all this stuff to see who's at risk of having health problems. And it did this for bicycling related injuries and for helmet use. And I thought it was particularly pertinent to our clinic population. So they identified these different subpopulation groups, and one of them was recent immigrants. And per this chart, higher number of immigrants who arrived recently, meaning what they defined as within the last 5 years, inconsistently wore their helmets, and fewer of them always wore them, and more of them never wore a helmet when you look at these figures. And for example, 19.2% of immigrants in the last 5 years wore a helmet, whereas for those born in Canada, the figure was 26.1%. So really less helmet use there. And they also found out that these groups are at increased risk of being hurt. New immigrants had a 1.35-fold increased risk for bicycle-related injuries, meaning per this adjusted relative risk here, they were a third more likely to be injured while biking. For example, those male students we talked about who are at risk had about a 2-fold increased risk for bike-related helmets. And as you know, in these groups, per the last slide, we're also less likely to wear helmets. So just like a lot of our clinic patients, new immigrants are at increased risk of being injured during a bicycling accident. And to me, again, that should matter to us because these are our resident clinic families who we love and take care of. And this definitely got my attention because there's something we can do about it. So that led me to look at what helmet use is like in Africa. Because again, that's where these families come from, most of them quite recently. And I found that bike helmets are not the norm in Africa. Nothing about not wearing a helmet is our clinic families' fault. It's just simply not the norm in Africa. And that is to do with cost, their availability, and also cultural norms. In some countries, people don't wear bicycle helmets, and that doesn't mean bicycling in those countries is any less safe. For example, in Amsterdam in Europe, almost no one wears bike helmets, but they have almost 1/3 the injury rate places like New York and Boston have for cycling. And that's because they have protected bike lanes in Amsterdam. That's because motorists receive additional training in how to interact with cyclists on the road. That's because biking safety is integrated into the school curriculum. It's a complicated issue, but I want to emphasize this isn't that biking is unsafe where these patients come from. It's just that they're not used to wearing helmets for a variety of reasons. So again, biking in the DRC, Angola, or wherever, it's not that it's safe. The only country I found that had a bike helmet law was South Africa. And children, and I want to emphasize that this isn't just about the children who've immigrated, it's about their parents, because parents are role models, and it's well established in the literature that children will wear a helmet if a parent wears a helmet. And a lot of these parents aren't wearing helmets because of their cultural experiences in these places. And children, per the study in Pediatrics in 2008, are 9 times more likely to wear a helmet when riding with a helmeted adult as compared to a non-helmeted child companion. So again, having that adult role model is really important. So, and a lot of our clinic patients are not set up for success because they're not riding with adults or around adults who understand helmet usage, wear a helmet on their own, see the importance in it, and all of these other things. So we kind of have a population that unfortunately is not set up for success here in Portland. So let's just talk about the resident clinic very briefly for those who don't work in the resident clinic. So there are about 2,700 children served, and there are hundreds of refugee and asylee families that we care for. And among them, there's 37 different languages spoken, the most common being Somali, Arabic, and French. And most of these patients have a low socioeconomic status. 81% of them are insured by Medicaid. And again, patients and or their parents, these family units, come from countries where helmet usage is not a social norm. They're not used to it. And that's something that was brought to my attention. So this made me think of advocacy, and in particular, community advocacy. For those who don't know, advocacy means speaking out on a child's behalf. That's like a very simplified definition. And it kind of assumes there's a problem that can be fixed. It can mean speaking out to help an individual child, for example, like calling that child's teacher at school and really, you know, trying to coordinate care, trying to help with their accommodations. Or it can mean speaking out to influence the health of a group of children. And that's kind of what I'm interested in. So community advocacy kind of has this larger focus on a group of children, and it centers on the idea that children's health is influenced by social, economic, environmental, and political factors in the community. And again, that goal is to improve the health of that group of children in the community. And it involves systemic community level change through organized partnerships. And those partnerships are often formed between local organizations like Maine Health, or schools, families, businesses, healthcare providers, all different stakeholders. And an example of that might be pairing disadvantaged families with a diaper bank, like the past resident of ours did, or working with a food bank to address food insecurity, school lunch programs, or even a bike helmet program. And so I came up with this project to improve access for to helmets for those between 6 and 18 that were cared for by our resident clinic. And My other goal was to kind of identify this population of children that needed intensive counseling and follow-up to ensure helmet use kind of as like a secondary aim. And long-term, I wanted to 75% of the children we cared for in the clinic helmeted by the beginning of next summer. So like a little over a year from now. And I came up with that 75% because in these states that have integrated bike safety programs like education in the schools, bike rodeos, local enforcement by police, and all these things, you can really get helmet usage to about 50–60%. And I was kind of shooting for a little bit above that. To me, I thought that was a good goal, reading these different studies. And so my initial plan that I rolled out last summer was we would figure out which kids needed helmets in clinic and ensure we give them out. So at the start of each well child visit in the resident clinic, an RN or MA would do the safety screening tool. It says, do you have a helmet? And the only answers are yes or no. And if the child didn't have a helmet, the resident or NP could offer the child a helmet. And that would involve printing a letter that almost served as a voucher that child could take to a local bicycle store to get a professionally fitted helmet in a color of their choice. It was grant funded. And I would be tracking these demographic factors like the patient's name, their medical record number, the language they spoke, when we screen them, whether or not they had a helmet, and these other things. And again, this was rolled out a little under a year ago. But I partnered with a local bicycle store called Allspeed that's over by Trader Joe's in Portland. And this is to be a local bicycle store where children could be professionally fitted. And I chose to partner with a local bicycle store because they had good knowledge of local roads, trails, parks. Sorry, excuse me. And other places where children were riding. So to me, they really understood the types of helmets that a child would need in the Portland area. And so they kind of knew the market and they knew what was needed to keep these kids safe. And they also had a really convenient location on multiple bus lines right in the middle of Portland, kind of like strategically positioned to do this. So we have been giving out the Bell Sidetrack 2 Mix, which is the helmet we're giving out. And these are new helmets that retail for about $70. They offer strong posterior and lateral coverage. They get excellent comfort ratings. They come in a variety of different neat colors, as you can see. And they're really easy to fit. You can essentially place this helmet on a child's head, turn a dial in the back, adjust the chin straps, and a kid's ready to go. Most kids will wear the same size of this from about the time they're like 11 or 12 till they're young adult. And for those wondering, we can't give out used helmets. It's just not safe. I think our legal department won't allow it, and for good reason. That's because used helmets have an unknown impact history. They can have microfractures, they can fail. Over time, they can essentially the foam degrades. And of course, we would be liable if a child took a fall on a helmet that was not up to par. So we have to give out new helmets. And I got some pretty mixed results from doing this. We performed 590 well child checks through June 1st, from June 1st of 2020 through just a couple days ago. 323 of those children underwent the safety screening, or just under 55%. 113 of them screened no for helmet use. So we printed 27 letters to give those children free helmets, and which is about 23% of those who screened no. And that's about 8.36% of the total number screened. And only 4 bicycle helmet letters were redeemed for helmets at the bicycle shop, which is not a lot. So I looked into that a little bit, which was part of my initial plan. And I think there's a couple possible explanations for that, right? There was definitely some drift. I mean, I think, we all work in clinic and we know it can be challenging. And it's tough for MAs and RNs to ask those questions at the start of every well child check. They're very busy times. Parents bring their own agenda, and for good reason. And we always don't have control as to whether or not there'll be time to offer a helmet. And residents are busy. During a typical well child check, sometimes something is to give, and it can be the helmet screening. And the spike in COVID cases over the winter definitely played a role. Many clinic families are simply staying indoors, and it likely interfered with them getting to the bicycle store to redeem these vouchers. And of course, the winter season in of itself, it's from someone who likes spending time outside, it's tough to think about biking when you wake up and it's kind of in the teens out and breezy. So I called the parents who got these letters. I called 20 of them, and I should say got through the 20 of them, and asked them, what was going on, just to offer a friendly reminder to say, hey, we gave you this voucher, we should redeem it, we should make your child safe while riding a bike. And I got a lot of different explanations as to why the vouchers hadn't been redeemed. Parents told me it was too cold to bike. They were trying not to leave the house during COVID. The bicycle store was simply too far for them. They forgot about it. Or a couple of the families said they didn't understand how to get there on the bus. They were relatively new to the Portland area and they just didn't know how they'd get to the bicycle store, which is more than understandable. So now we have a new process thanks to Mary Ottolini, and I think she did some direct advocacy by contacting the legal department for me, which I'm very thankful for, and it helped me obtain special permission to distribute the bicycle helmets directly from clinic, which I think will make a big difference. And I think that this is a clear example of advocacy. In this case, advancing the helmet project was essentially just about connecting different stakeholders in the community and bringing them together to do something nice for the health of the children we serve in our clinic. So now helmets are being directly purchased from Allspeed with the grant monies in batches of 10 and stored on site here at 22 Bramhall at the Pediatrics Clinic. And we're going to be giving them out directly from clinic at the end of well child visits. And the screening process is unchanged. We simply ask that safety screening question. We print out the letter. And this time we leave it in the envelope, an envelope I'm going to put up in clinic, and then we can give out the helmet. And the residents, like me, the MAs and the RNs, are simply going to measure head circumferences and fit the helmets. We're going to put the fitting instructions on the helmets. Again, it's just a question of measuring the head, turning a dial, and adjusting some straps. And the rollout is going to begin right now, today, the 8th of April. So in terms of where we're going with this, the goal is still to get 75% of the children who we see in clinic, specifically those who ride bicycles, helmeted by next summer. In the future, what I want to do is make a screening tool that will essentially flag a patient's chart that will indicate if the child has an increased use of not wearing a helmet. Because there's definitely an at-risk population out there. That population is probably pretty unique to Portland, given the unique mix of patients we see here. And so it would be nice if in advance we could say, hey, this patient is at increased risk of not wearing a helmet because they're a new immigrant, they're an adolescent, they're a male, whatever it is. And we should give them a helmet off the bat and offer them counseling. And I also want to expand the program to other clinical sites ultimately. For example, other MMP sites that serve at-risk kids, and particularly our inpatient unit floor. Because I think if a child has an injury, if a child's riding a bike, depending upon why they're admitted, that child should be able to receive a helmet as well. And of course, when I have more free time, I'd love to do some advocacy, because I think helmets are only as good as the bicycle network they're used in. And we need to advocate for safer bike lanes, funding for bicycle rodeos, bike education in schools, and these kinds of things, which I'll talk more about in a moment. But this led me to think whether or not these helmet giveaway programs work. And there's some pretty mixed data out there. This is one of my favorite studies. It's from Pediatrics, almost well over 20 years ago now, but I love it because it was like the purest helmet giveaway program I could find. Essentially, at a town of about 10,000 people in Texas, the school gave out 403 helmets to kids K through 8. And they coupled that helmet giveaway with bike rodeos, incentives, helmet education. And then they had students and parents report on questionnaires how often they were using helmets. And they got great result. Helmet use increased from 3% before the program to 38% at the end of the next school year. But then the program kind of stopped. Teachers and administrators stopped reminding kids. It kind of faded away. And by the next year, helmet use had decreased to only 5%. And in the study, they kind of felt that was the result of a lack of reminders and also peer pressure and a few other factors. So helmet programs are only temporarily effective, and they need to be kept going strong, and they need to be paired with other mechanisms to get kids to wear helmets, like reminders and like local advocacy, like we just talked about. So some lessons I learned: children need to be reminded to wear helmets. They need positive reinforcement. Ongoing education is key. And again, we can start a helmet program, but we also need to make our communities bike friendly. Like a helmet program is just one part of that puzzle. We need those education events, bike rodeos. In case I didn't say that earlier, that's really when children get together, take a ride, and and learn about bike safety, ride as a group, and it fosters this sense of biking community. Education days at schools where children learn about road safety and other things. And of course, we need to also get out on the state and local level for additional safety legislation. And that kind of is tied into these local efforts, right, to eliminate hazards, for example, like wheel grabbing grates, like, for example, the grates that cover sewers can grab, they're not the appropriate ones, can grab bike tires on children's bikes. Children need dedicated and protected bike lanes striping to keep motorists out. We need safe places to park bikes and all these things. So bike helmets are really just one part of a larger equation, and it's kind of a complicated issue. So what can we do as pediatricians? And I think the AAP policy statement on bike helmets is an excellent summary of what we can do. And that is, we should advocate that all children should wear a properly fitted bicycle helmet made after 1999. That 1999 date is just because after that date, helmets tend to have that posterior cage. There are a lot of improvements made to them. Children should never use a damaged helmet, and that includes everything: scrapes, drops, cracks, anything. There's no reason to be using a damaged helmet. Children should wear bicycle helmets, even if just bicycle passengers. So if they're in one of those little tow trailers, they're on a seat behind the bicycle, whatever, they still need to be helmeted. And parents should discard any helmet that's involved in a crash or otherwise damaged. It's not okay to find out a child was in a crash during a visit and tell them they don't have to throw out the helmet. The helmet should be thrown out. Helmet should be replaced every 5 years. Foam doesn't last forever. It degrades. It's exposed to changes in temperature in garages, and even small impacts. It's simply falling off the bike handlebars where it lives when it's not in use can add up. Helmets need to be replaced every so often. And of course, like we just talked about, helmet use is only one aspect of bike safety, right? Children need to practice the rules of the road. They need to be visible. They need to have training on how to use their bikes. All these things are very important. So in terms of future directions for the program, I think when I'm in Rochester, I'm going to try to partner with the local practice to start a helmet program and maybe try to help bridge some of that divide between inpatient pediatrics and outpatient pediatrics. And I'm also going to partner with one of our interns. I guess recently that person has become Heather Riley, try to advance the bicycle helmet in Portland during my absence. So in terms of the objectives of this talk and the things we went over, I provided an introduction to bike helmets. We talked over the protection they offer, the technologies that are involved with them and their fit. I went over the added safety that they add, like, for example, like they reduce the chance of skull fracture, upper facial fracture, and soft tissue injuries, significant head injuries like subdural and epidural hematoma, and the umbrella term of TBI. I also talked about my advocacy project. We promoted the bike helmet distribution program at clinic as an easy, quick way to increase helmet use and protect the children that we serve in and around Portland. And we showed that that population is at increased risk of not using bike helmets. So I just want to say thank you as I'm wrapping up to a number of different people. I want to thank my parents, Wayne and Phyllis Trigg, for being supportive. I want to thank my girlfriend, Haley, for putting up with all the late nights I worked on this presentation. I want to thank Mary Odolini, who did some direct advocacy on my behalf and on the program's behalf to help make this a more effective program. I want to thank Logan Murray, who initially started the bike helmet program several years ago and tried this. I want to thank Steve DiGiovanni in the clinic, who has been a wonderful mentor with rolling this out. I couldn't have done any of it without him. And I want to thank Tom Reynolds and Carol McCarthy for giving me feedback on my presentation and for encouraging me. So now I'll take any questions or comments. And again, the for the attendance number, it's 59113. Thank you.
Dan, that was just fantastic. It's so clear, how passionate you are about this topic as a whole, and I'm so happy that you got to do this great longitudinal project in advocacy on bicycling safety and helmets for our resident clinic patients. It's really, really fantastic. I'm so glad to see this, how it came to fruition and your and the initial data from your project and how it's moving forward. Really, really well done. I have a sort of comment for you and a question about your future. This project was so great. You've got this awesome future ahead of you as a hospitalist, and you've explained well how your community advocacy works for this project. And, you touched a little bit upon legislative advocacy as a future direction, and I was sort of thinking about how cities in Europe like Amsterdam, like you mentioned, where there's less helmet wearing, but better bicycle safety due to some of the social and legislative norms that are in place there. How do you see your own future in that area? Can you take the passion you've just displayed for community advocacy and take it to legislative advocacy to change bicycling safety to an even larger degree in Rochester? Do you think that's possible?
I think that's possible. I think that I think it's definitely possible to advocate on the state and local levels for improved bicycle safety. I think that's really the second phase of this. I feel like after we have a well-established bike helmet program here that's given out a few hundred helmets and we have a good data set, we'll be in a good position to say, hey, we've made this difference. We've handed out these bicycle helmets to these kids who need them, and we're making a difference. But now we need to take this a step further. We need protected bike lanes. We need striping. We want to come into these schools and talk about the rules of the road, visibility, and these other things. So I think this is really a multi-tiered project. And I think that from my experience with giving out helmets now to date, I'm going to be in a better position, particularly now that I understand some of the data in the field and the research that's been done, to advocate and say, hey, in these other places where biking is safer, you know, they're doing these things. They have these protected bike lanes. They have this striping. The rules of the road are learned at a very young age in school, and we should probably be doing these things. Because I mean, I think in a broader sense, helmets are almost like an American thing due to the way that pedestrians in America interact with people on our streets, with motorists on our streets.
Wonderful. So a couple of questions from the chat here. Shannon Bennett wants to know, does the clinic fit or offer helmet for all ages in clinic, or is there a younger age limit? And is this same type of helmet recommended and available for infants and toddlers as well?
Oh, that's a good question. So that's like a whole other field of research. Is infants and toddlers who are using stride bikes and tricycles and training wheels and all these other things. So yes, we do want to give helmets to that population. And right now, to keep things simple, we only have 2 helmet sizes. We have child, which is I think like a 48 to 55 centimeter head, and youth, which is like a 50 to 60 centimeter head. So there's some overlap. And I think after we get better at fitting and we do this for a little bit, we will give out helmets to that age group and we will expand. But right now, due to funding, due to the fact that this is relatively new, we're just going to give helmets to those children who are school age to adolescent right now. To answer the rest of your question, yes, the same bike style helmets are recommended for infants, like those same ones, like the one we're giving out, the Bell Sidetrack 2. That exact helmet doesn't come available for toddlers, but there are multiple helmets on the market. They sell them at all speed too, that are perfect for that age group.
Great. Pam Dietz asks, since parental helmet wearing influences kids wearing, is there education around parents wearing helmets too?
It's that's a really good question. And I guess this is something I struggled with in terms of my own experience in clinic, because oftentimes we're not just treating these children, we're treating these families, and we're there as resources for them, whether we're addressing postpartum depression or we're pairing, parents with resources in the community, like diapers or food, or arranging for them to PCPs or other things. And you're right. I mean, it's kind of difficult to give a child a helmet and to say this is this one thing that this one person in the household needs to do, but the others don't. I mean, we probably should be giving helmets out to the entire family. And I think that once there's more funding and once this is better established, that'd be a great goal.
Wonderful. We have a great comment here from Erica Schumacher, a pediatrician up in Franklin County, who really feels like this could be, helpful in her part of the state as well, especially thinking about the way that the size and the fit of the helmets work, meaning that they see kids wearing them in a way that limit their effectiveness, and looking at trying to find a good tool to teach proper helmet fit in the office. And you did share that one slide that shows how to fit. Perhaps that's something we could include in the Children's Health Service line and maybe look at ways to newsletter, maybe look at ways to try to expand this type of project to other places in the state.
Absolutely. I also want to add that, I know there's that cost barrier, availability, the helmet we're giving out is $70. It's a lot of money for most Maine families. That's not insignificant. And they cost a lot of money, but the fortunate thing about them is that the more modern helmets seem to be better equipped to grow with a child, which is one thing I didn't say in my presentation, which is that, for example, the youth size helmet that we hand out in clinic, I mean, I'm making up this range, but from what I've read and from what Bell Helmet says, and from what I'm hearing from Allspeed, they really like a helmet like that really should be able to fit a child from the time they're like 8, 9, 10 years old into well into their teens. Whereas like some older helmets, like children outgrow more. So I think that's part of the reason we want to get children these more modern helmets is they grow with them and they last longer.
Awesome. Logan writes, Dan, great talk on an issue close to my heart. Logan, I remember when you and I were residents and you initiated a similar project. So he writes, is there similar data on efficacy of ski, snowboard, and skateboard helmets?
Yeah, so that's like a whole nother field of helmet, helmet studies. And I was actually initially going to give this talk talking about all kinds of helmet use and going to cover things like skiing and snowboarding and skateboarding. But yeah, and it's like very interesting because the helmets work very, very differently across those sports, both in terms of the protection offered, and they're really completely different pieces of equipment. But yeah, to answer your question, there is similar data, and there's some very detailed studies out there about ski and snowboard helmet use. There's some in Vermont where they even looked at children falling skiing and snowboarding, and they analyzed all those falls like from camera footage, and they had hundreds of them. So yeah, I mean, yes, it's very well studied. There's a ton of data.
Great. Lastly, Jay Vance, one of our MedPeds residents, writes, I know Portland Gear Hub works with the adult immigrant population to teach them the rules of the road and give out free bikes. Do you happen to know if they do anything with kids?
They do help kids and they do give out bikes, and they're a wonderful resource. And part of the thing I'm struggling with that's so difficult with this is that we need to give out new stuff, and a lot of their stuff is used. And I think that's kind of like this problem that's simmering in the background right now for me. And I think that ultimately, if we are going to have a long-term sustainable program here, we'll have to give out used stuff. I think like maybe we'll come to that reckoning when it comes to obtaining more monies or something. But yeah, they do great work, and I wish we could give out used equipment like they do. I think they do wonderful things.
Well, great. We're coming up on 10 a.m. here. And again, Dan, you should be really proud of this project. And this was a great presentation and a really great way to share the advocacy work that's being done in our clinic that you've been a part of. So great job. Thank you so much.
Thank you. Have a good day.